Hello, I'm Ian Paul, and I'm the Director of Medical Neuroscience and Behavior 2. This is the Case Facilitators Introduction for the academic year 2021-2022. First of all, welcome to the course, and thank you for sharing your time as a Case Group Facilitator. I hope this presentation will help prepare you as a facilitator, as well as give you some tips on managing your groups. In this overview, I'll describe the course objectives, the flipped classroom model, how to access the course in Canvas, the changes in the course due to the evolving pandemic. I'll explain the role of the Case Group Facilitator, discuss the elements of student-doctor feedback, as well as give you some techniques for facilitating discussion. As mentioned, I direct the course. For those who don't know me, I'm a professor and the Director of Medical Student Education in the Department of Psychiatry and Human Behavior. The course coordinator is Barbara Daniels in my office, and the neurology contact is Ashley Smith. This is our contact information. It's probably a good idea to include our cell numbers on your phone in case you run into any last-minute problems. This information is also included in the Case Facilitators Guide. The Psych MSc email is followed by both Mrs. Daniels and myself. If you use email to contact us, it's always a good idea to include a copy to that address in the event that one or the other of us isn't in the office. Medical Neuroscience and Behavior 2 is an M2 course that straddles the fall and spring semesters. It integrates material from psychiatry, neurology, neuropathology, CNS pharmacology, and neurosurgery. This course focuses on pathology and treatment, in contrast to the first-year Medical Neuroscience and Behavior course, which is oriented toward normal structure and function. In addition to being horizontally integrated within the M2 year, MNB2 serves as a bridge in the Medical Neuroscience and Behavior series between the preclinical M1 year and the M2 clinical clerkship year. There are 5 overarching learning objectives in MNB2. By the end of the course, we want students to be able to demonstrate knowledge of the signs and symptoms of frequently encountered neurological and psychiatric disorders. Moreover, we want them to be able to apply the techniques of both the neurological exam and the psychiatric interview in patient encounters in order to identify the relevant signs and symptoms of neurological and psychiatric disorders. Based on this information, students should be able to formulate diagnoses and treatment plans for these disorders. Prior to 2015, almost all teaching of the material in Medical Neuroscience and Behavior was lecture-based, with very little active student involvement. Between 2015 and 2019, I was able to increase the role of active learning exercises by adding case groups. However, in 2019, I decided to shift to a flipped classroom. For those of you who aren't familiar with the concept, essentially, the flipped classroom moves traditional homework study of foundational material that's completed after a lecture to pre-work that is completed prior to class time. Class time is focused almost entirely on active learning tasks. However, this approach requires significantly more preparation by instructors and requires an increased number of instructors in the classroom. This brings up the obvious question, why change? The reason the format of the course changed was primarily to address the fact that learner characteristics and attitudes change during development. In traditional pedagogy with children, the learner is highly dependent on the teacher to select what and when material is learned. Of course, children have little prior experience with most material, and as a result, the teacher is in control of the material learned, as well as placing the material in context. Most learning among children is the acquisition of concrete knowledge: who, what, where, when, why, and how. Finally, while children do suck up new information pretty indiscriminately, The motivation for classroom learning is usually external, coming from teachers or parents. In contrast, in adults, almost all of these elements are turned on their heads. Adults tend to want to self-direct and evaluate their own learning. In addition, they very much want and need to fit new information into their prior knowledge. What adults learn is very much predicated on the relevance of that material to them and their goals. Adults also tend to learn best by problem solving. With all that said, adults are most motivated to learn by internal reasons. For these reasons, in 1984, Malcolm Knowles coined the term andragogy to distinguish adult learning from pedagogy for children. The flipped classroom process makes use of these concepts by utilizing self-directed learning prior to class time. Students in class are then able to assess and review what they've learned with a content expert such as you. Finally, the student employs their new knowledge in problem-solving activities with a coach or facilitator. In MNB2, the factual content is largely online in videos, narrated PowerPoints, and pencasts. In the large class setting, review of PBLs and guided case reviews help students synthesize that factual knowledge to begin solving problems. Finally, in the case groups, students get actual hands-on opportunities to practice problem solving in a realistic setting. Medical Neuroscience and Behavior 2 is arranged in 13 topic blocks, which each cover a general topic such as seizure or mood disorders. Each block begins with self-directed and problem-based learning. Students then meet with a content expert to review their PBL assignment and to go over several additional cases in a guided case review session. A topic block finishes with case-based learning with small groups of students examining or interviewing standardized patients. This table gives a breakdown of a typical topic block. The first half of MNB2 focuses on topics that are largely neurologically focused, while the second half focuses on psychiatric disorders and treatments. Between November and late January, we cover 6 neurological topic blocks, beginning with pain and pain management, and concluding with stroke and vascular diseases of the CNS. From late January to the end of March, we cover 7 topic blocks in psychiatry, beginning with neurocognitive disorders as a bridge between neurological and psychiatric conditions, and concluding with neurodevelopmental disorders. This year, we decided to break out substance use disorders into their own topic due to the prevalence and importance of these disorders. We use Canvas as our learning management software, and on the MNB2 site, you can find all the materials pertaining to the course, including the syllabus, schedule, self-directed learning material, PBL assignments, and case materials. To get to Canvas, you can either log in via the UMMC intranet or go directly to the Canvas URL. Once in Canvas, look for Conj 628 for 2021-2022. To log in via the intranet, simply look for and click the Canvas button under the Education tab. This will take you to the Canvas homepage. Click the Conj 628 Medical Neuroscience button. This will take you to the MNB2 homepage. You can find our office contact information on this page. In addition, from this page you can find the syllabus, the instructional material, including a copy of the Case Group Facilitators Guide, and the calendar for the course class times. All teaching materials are organized like this by topic block. I've moved all narrated PowerPoints created by faculty to a YouTube channel. These are organized as playlists at the top of the topic block module. This year, we're also using pencasts from osmosis.org. Like the PowerPoints, all of the Osmosis pencasts for a topic block are organized into playlists at the top of the module. Material within a topic block is organized into units, such as this one on ascending and descending control of pain by Dr. Anesh Raghunath. Each unit normally begins with a study guide outlining the material in the unit and giving recommendations for supplemental reading. This is followed by a readiness assessment test, or RAT, that students can use to check whether they have the necessary prior knowledge to understand the topic material. Then, there is the learning material that I refer to as asynchronous teaching material, or ATMs. To make the material more learner-friendly and available across platforms, we're working to revise all previous lecture material into multiple shorter video chunks of 10 to 20 minutes each. Not shown here is the formative quiz, which students are required to complete after reviewing the ATMs. This is a 4 to 5 question, very low stakes quiz that allows students to check whether they've understood key points from the learning material. In contrast to last year, all classes are now in person for all students. However, to protect our standardized patients who may be older, immunocompromised, or have vulnerable family members, we are asking everyone to wear a mask throughout the class. Student doctors should be reminded to use hand sanitizer between standardized patients. There are 9 small groups of about 16 students each. Each group encounters 2 different SPs, each of whom presents with the signs and symptoms of one of the disorders under discussion in that topic block. For example, in the pain and pain management topic block, one SP presents with symptoms of migraine, while the other presents with lower back pain that is likely from a herniated disc. This is an outline of a typical case group session. You'll receive a case group contact sheet before each case group session that includes the names and photos of all of your group's students, as well as noting the student doctors for the day. Begin by identifying the student doctors and then let them decide the order of their exams between themselves. At that point, invite the first SP into the room for examination or interview. Remember, this is the first contact the students have with either a neurological or psychiatric exam, so coaching may be needed from time to time. When the student finishes examining the SP, check with the rest of the group to see if they have any questions or tests for the SP that they feel would be pertinent. Similarly, if you see something the student doctor missed, you can bring it up. After that, dismiss the SP and facilitate a discussion with the group about the case. The process is then repeated with the second student doctor and SP. After both exams are completed, you should use the remaining time for adding any clinical pearls of your own and fielding a question and answer session about the cases, units, topic block, etc. Be sure to let the students know 10 minutes before the hour that they can leave if they need to for another class. One of the better feedback tools for situations like this is the 1-minute preceptor model. It has 5 elements. First, get a commitment from the learner. For example, ask the student, based on your examination, what's at the top of your differential diagnosis? Next, probe for supporting evidence. In this example, you might ask what information led to the student's primary diagnosis. Then teach a general rule. It's particularly useful if you pick something you've learned from your clinical experience. Reinforce what the student did well. You don't have to be exhaustive, just the most prominent positives you observed. Finally, correct the most important errors you observed. Again, don't try to be exhaustive and focus on corrections that the student can readily implement with their next patient. When giving a student feedback, remember the SMART feedback mnemonic. Your feedback should be specific and avoid vague, positive, or negative comments. It should be measurable so that the student has a means of gauging their progress. Your feedback should always be actionable, that is, focus on something the individual can correct. For example, telling a student that they should always ask about suicidality and self-harm is actionable. Telling a student they have an irritating voice is not actionable. Remember, these are early learners. Make your feedback reasonable. That is, your feedback should be achievable by students at that level in the short term. Finally, your criticism should be timely and apply to the immediate situation. When discussing a case with your group, remember that in this type of learning, the students should be the ones driving the evaluation of the case. You can steer or redirect if discussion is going off the rails, but avoid trying to lead discussion toward a particular goal. Remember that the graded component of this part of the course involves submitting a case report with a differential diagnosis, so avoid giving your own diagnosis. However, hints and helpful statistics are definitely part of your role. Use your clinical knowledge to comment about disorders covered in the week's theme, or to ask questions of the group. It's always helpful to have a few conversation starters in your back pocket, especially if the group is hanging back from discussion. Finally, try to keep the discussion balanced. You're always going to have outspoken and shy students. Be ready to gently restrain the gunners or to draw out the wallflowers. I hope this presentation has answered your most pressing questions about the course. If I missed anything, please feel free to email or call me. Again, thank you for your time. Historically, these case group sessions are the part of this course that the students most value, and that value is largely produced by your role as a facilitator.